Hello, welcome to GP Notebook TV. My name's Dr. David Miller-Jones. I'm going to talk about some of the posters from recent ADA presentation. Many of these big diabetes conferences talk about sciences of the condition, but sometimes I leave feeling quite left out, in fact, that nothing has changed my clinical practice. Well, a few things have actually been brought to my attention that may alter the way I practice in the future. One of these posters looked at non-alcoholic fatty liver disease and cardiac complications of type 2 diabetes. NAFLD, as we know it, is common in type 2 diabetes, and it was proposed that that might be due to a cardiometabolic syndrome. The study was aimed to determine the relationship between hepatic fibrosis and cardiovascular abnormalities in type 2 diabetes. Cardiovascular complications were more common in patients with liver disease, as coronary heart disease was 20% in non-NAFLD patients, but rose to 37% in non-alcoholic fatty liver disease, 36% in patients with NASH, and 53% in patients with fibrosis. The ejection fraction was also reduced with patients suffering with NASH or fibrosis. This poster has confirmed that liver fibrosis is associated with impaired cardiac function and increased cardiovascular complications. So when we talk about cardiometabolic renal problems, we should also include fatty liver disease in this triage. That brings me on to another poster looking at GLP-1 use and patients with non-alcohol fatty liver disease. There has always been a caution with using GLP-1 receptor agonists in patients with liver disease. This study looked at liraglutide and NAFLD in patients with type 2 diabetes. 62 patients were recruited and were either on 1.2 or 1.8 milligrams of liraglutide, and the follow-up was over 26 weeks. All showed a significant reduction in weight. A significant higher proportion demonstrated reversibility of liver fibrosis, and all showed an improvement in glycemic control. The conclusion of this study was liraglutide significantly reduces hepatic fibrosis and effectively causes reversal of elevated transaminase, along with weight loss, blood pressure, and reduction in glycemia. Therefore, my practice will change because I'll be more confident at using GLP-1 agonists in patients who have got liver disease. There's also been some concern regarding the best treatment in patients with cardiovascular risk. Once again, another poster looked at a matched cohorts comparing patients with type 2 diabetes, whether it be best to initiate a GLP-1 RA or basal insulin. The initiation of GLP-1 RA was associated with lower risk of myocardial infarction, stroke, and a lower risk of hypoglycemia. This poster actually supports the recent guidelines that in recommending that GLP-1 RA should be used before basal insulin in type 2 diabetes when they have achieved inadequate control on metformin alone. I know with cardiovascular outcome trial, particularly with semaglutide, there has been concern about retinopathy. There has been a poster of GLP-1 RA and retinal risk. HbA1c change was found to be associated with retinopathy outcomes, no matter what GLP-1 RA patients were on. In fact, there was linear progression, with the more significant drop in HbA1c was linked with an increased risk of retinopathy. So it is not the GLP-1 RA that is causing the retinopathy, it is its effectivity. Now, the problem with GLP-1 RAs is some are more effective than others. So the advice would be in patients with established retinopathy to use GLP-1 RAs with caution. But remember, any significant drop in HbA1c, whether it be using insulin or any oral agent of hypoglycemia, may actually worsen the retinopathy. So GLP-1 RAs we know cause GI side effects, and one poster looked at the use of semaglutide and whether we could actually predict which patients are more likely to get GI side effects. There was no real evidence to suggest any particular cohorts we should use with caution, but there was a suggestion that it was more associated with frail and women who are more likely to have positive problems from gastrointestinal upset. The study also looked at the therapeutic effect of HbA1c and weight loss, and the association was there whether patients had GI side effects or not. So with GLP-1 RAs, the current guidelines in the UK with NICE suggest that we should be aiming for an HbA1c reduction of 1% or 11 millimoles per mole within 6 months and a 3% weight loss. If patients do not achieve these targets, the guidance would suggest we should discontinue the GLP-1 RA. A real-world study of GLP-1 RA switches to semaglutide, the expert study, looked at whether it'd be worthwhile changing to a once-weekly GLP-1 RA and whether this would give benefit. The study showed that there was associated significant HbA1c and weight reduction independent of the previous GLP-1 RA used. So my practice is likely to change if patients are not achieving target with their current GLP-1 RA. I'm more likely to trial them on a once-weekly preparation. And for the future, we have oral semaglutide. The Pioneer trial program looked at oral semaglutide and demonstrated that oral semaglutide was more effective in providing both HbA1c reduction or HbA1c reduction of greater than 1% and weight loss of greater than 5% compared to both placebo, sitagliptin, liraglutide or empagliflozin. Thank you for listening.